Mr. Sodhani.
Good morning. Good morning to everyone. Thank you, Dr. Moitsford, for your kind introduction. I'm honored to join you today in the 22nd Annual Medicine Day Student and Fellow Research Day. The Sodhani Family Foundation members and I are excited to support Rutgers RWJ Medical School Department of Medicine. I would like to thank for the amazing work done by the residents, fellows, and physicians to help better the lives of the patients in the community. As young physicians, you are already making an impact in the field of medicine. Please continue to learn, ask questions, and find answers as you go through your career. It is our honor to recognize the winners today with awards. We have been fortunate to have good health. It is extremely important for us to support the health and well-being of our community. We do believe that giving back to our community is the least we can do. On behalf of the Sodhani Foundation, I congratulate you and thank you for your dedication and contribution to our community. Thank you all.
Thank you very much, Mr. Sodhani, and the department thanks the Sodhani Family Foundation for their generosity over the years. It's my honor to be introducing the presenters for today's grand rounds. First, I want to thank my co-vice chair of research, Dr. Christoph Buettner, for helping me organize this and the judging process. I want to thank our committees who reviewed all of the faculty on our committees who reviewed all of the submissions. I will say that it would be easy to expect that in the year that we've had this past year, that the quality of the research would take a dip as people were just pretty much overwhelmed with getting through the day-to-day activities. But it was really impressive, not only the amount of research projects that were submitted, but the quality of the research projects that were submitted by our trainees this year in light of it, despite everything that's been going on. So the faculty on these review committees, Dr. Buettner and myself, want to thank all of the residents and fellows for their hard work. The submitted projects, as you've seen going past on the posters, were outstanding. And it was quite a challenge to select awardees for this year. So again, thanks to everybody for helping in that process. I'm going to introduce, we have 4 oral presentations this morning. I'm going to ask each person to present for around 10-ish, maybe 10 to 12 minutes. And then we'll have a couple of minutes after each presentation for questions from the audience. Then after our oral presentations, I'm going to announce the winners of the poster awardees. And then you're going to have time to once again review the posters. We'll have them virtually being presented after those announcements. Okay. So without further ado, I'm going to introduce our first presenter. We have Janet Kai, who's going to be presenting on primary causes of hospitalization among patients with left ventricular assist devices. So I'll turn it over to Janet.
All right, good morning, everyone. Let me share my screen here and let's get started. Okay. All right, everyone can see okay? Perfect. So good morning, everyone, and thank you for the opportunity to share some of my work here on Research Day. Today, I will be speaking about a project I'm working on with my mentor, Dr. Akabwe, about the primary causes of hospitalization among patients with left ventricular assist devices. To provide a bit of background, left ventricular assist devices, or LVADs, are surgically implanted devices that augment or replace the function of a failing heart. LVADs have been used more and more frequently over the years in patients with end-stage heart failure, as both a bridge to heart transplant and as destination therapy. Severe complications such as infection, bleeding, and device complications after bad placement still remain a major issue. Based on literature review, patients of lower socioeconomic status have been shown to have worse outcomes in terms of survival after heart, lung, and renal transplants. So we were curious to see if this was reflected in post-VAD patients as well. Socioeconomic markers have been examined as risk factors for immediate post-operative complications and short-term readmissions, meaning within 90 days. However, the total burden of rehospitalizations and whether the primary causes for these hospitalizations differ by socioeconomic or demographic factors has not been well described. So we believe increased awareness of these possible associations may allow providers to tailor their practices or to target certain aspects to prevent readmissions. Our specific aim was to investigate if principal causes of rehospitalization after VAD placement vary by socioeconomic and demographic markers. And we hypothesized that primary causes of hospitalization would indeed vary by these factors. For our study, we utilized hospitalization data from HCUP, the Healthcare Cost and Utilization Project, specifically the National Inpatient Sample. This is a weighted sample of discharge records from nearly all inpatient hospitalizations nationwide, encompassing over 4,500 hospitals and about 96% of all inpatient hospitalizations. So we identified all hospitalizations between the years of 2012 and 2016 of adults over the age of 18 with a history of prior VAD placement. This included over 48,000 hospitalizations. Exclusion criteria included hospitalizations for initial VAD placement, presence of or implantation of fully implantable artificial heart, short-term mechanical support, and heart transplant. Primary causes for hospitalization based on ICD-10 and 9 codes, because the transition happened in the third quarter of 2015, were initially sorted into 15 groups, mostly based on organ systems, and then further collapsed into 7 groups of key adverse events based on various factors for presentation. So in terms of our primary outcomes, we looked at rates of hospitalization by primary cause based on organ system, as prior mentioned, as well as rate of hospitalizations of key adverse events. This is defined as a composite of GI bleed, VAD-related complication, pump failure, stroke, and device-related infection. This definition was created based on pre-existing literature in terms of, what were the major events that people were running into post-VAD. Differences within subgroups were assessed by chi-squared statistics, and to investigate the association of socioeconomic risk factors with key adverse events, we utilized multivariable Poisson regression model, accounting for age group, gender, race, primary payer median income, area of residence, hospital location and size, as well as year of hospitalization. A random effects component was also included to try and account for any clustering that might have occurred at the hospital level. This is a table that shows the characteristics of the hospitalized population that we included in our study. We did note that the age and gender distributions each year over the study period were fairly similar, and basically approximately 75% of hospitalizations each year were male patients versus 25% were female, and this stayed pretty consistent throughout all the years as well. We also noted that each year, patients with Medicare represented the largest number of hospitalizations, followed by private insurance, and then Medicaid. Each year, the number of hospitalizations post-LVAD also seemed to increase, as shown by the rising N value across the chart, possibly related to increased implantation of VADs or potentially longer survival rates after VAD placement, though this might be something that would be interesting to look into more in future. The table on the left shows the 7 primary categories of key adverse events that we looked at, including arrhythmias, device complications, GI bleeds, heart failure or cardiomyopathy, infections, strokes, including both ischemic or hemorrhagic, as well as other causes. The chart on the right shows some of the less frequent causes for hospitalization that we included under our other category, such as any GI issues other than bleeds, or any neurological, psychiatric issues. Frequencies for each of these subcategories tend to be around 5% or less. And these were some of our significant findings. So this chart shows the overall rates of hospitalization for key adverse events after bad placement, not broken down by any demographics. So this is just an overview. Infection was the most common cause for hospitalization post-bad placement at 15.8%, followed by GI bleed at 14.2%, and heart failure / cardiomyopathy at 13.7%. We noted that infection was the most frequent primary cause of rehospitalization after that in younger adults, ages 18 through 44, compared to about 15.1% in the age group of 45 to 64, and even lower at 14.8% in the over 65 age group. This was statistically significant with a chi-square p-value of less than 0.001. GI bleed was the most common cause in adults over 65, representing 18.2% of hospitalizations, and was less frequent with each of the lower age groups, representing about 13.7% in those between 45 to 64, and just 3.7% in those between ages 18 to 44. Also statistically significant with a p-value of less than 0.001. Device complications occurred most frequently in younger adults compared with both of the older age groups, around 6.4% for our youngest age group, 4.4% in our 45 to 64 age category, and over 65, it only represented 3.7%. This was also statistically significant as listed. We found that frequencies of hospitalizations were actually similar between males and females for all primary causes of rehospitalization. We also found that Hispanics had the highest frequency of rehospitalization for heart failure at 16%, which differed from our Black individuals at 14.7% and white individuals at 13%, also statistically significant as listed. In conclusion, significant demographic differences definitely do exist in the frequency of primary causes of hospitalization in adults with prior bad placement, especially by age and race, as we had discussed. We believe a future study is necessary to understand the role of socioeconomic factors such as median income or area of residence in hospitalizations, both long-term and short-term after bad placement. For future directions, we are now working on incorporating the 2017 NS data, which was recently released. We will be running Poisson regression models again for our key adverse events as a composite outcome with data from 2012 through 2017, with assistance from our Rubies program. Finally, we'll complete our manuscript for publication. Thank you very much for sharing your morning with us.
Outstanding. Thank you very much, Janet. That was wonderful. We'll open things up for a few questions. People can either put a question in the chat box or please feel free to unmute yourself and ask a question. While we're waiting, I'll ask. It looked like the other category was still pretty high group. Can you give us a sense as to what types of things were in that other category?
Yeah, so, I had discussed that with Dr. Akabwe as well, because I was like, it does look like a big chunk, but it was made up of so many different categories that were like 1%, or there are certain things like someone was admitted for a tick bite or something like that, listed as a primary cause. And we're like, there's only one patient out of those however 40,000 hospitalizations, and we're like, is that going to make a big difference? Ideally not, given the bigger picture. But it literally encompassed so many different things. And I think that's why initially we started, when I first consolidated, it was like 30 something categories. And then I was like, that's way too many to display in any pie chart. Like, who's ever going to be able to sort of see that? And we kind of had to consolidate further just into organ systems. And then, and we spoke with one of Dr. Akaboy's like heart failure specialist colleagues over at Northwestern, Dr. Akawosa. And he had mentioned, some of the bigger adverse events that, as someone who deals with this very frequently, that he is most concerned about. So we decided to focus a little bit more on those.
Perfect. Other questions? Go ahead.
Jim Cornwell's great presentation. What about comparing it to another population of similar heart failure patients without VADs? Because the device complications as a category weren't that prominent, but many of the complications may have been related to the device, to see if there are differences between similar patients who have VADs versus don't have VADs.
Oh, you're muted, Janet.
Oh.
Yeah, that's definitely something, we could look into doing in the future. I think for this particular project, we were most interested in outcomes after VADs. I think we would have to look more into whether like the HCUP database could help provide information, I think, to do that, and how to kind of try and line that up. Our inclusion criteria at the very beginning was set just to include patients who already had the VADs, since that was kind of the main idea of our project. So.
There's one more question in the chat. What kind of anticoagulants are LVAD patients usually on if they have no other indication for anticoagulation?
So we typically do see a lot of like warfarin, et cetera, for this. And the INR goal is actually a little bit higher for these patients with the VADs. But, that's kind of what we typically do see.
Wonderful. Thank you very much. That was excellent. We're going to move on. Our next presenter is Mohammed Arslan, who's going to be presenting on the impact of rapid diagnostic assay on duration of broad spectrum antibiotics for gram-negative bacteremia. So turn it over to Mohammed.
Hello, everyone. Good morning. I'll just share my screen. All of you can see the screen. Okay, so my name is Arslan. I'm one of the secondary infectious disease fellow. The project that I will be discussing today is titled Impact of Rapid Diagnostic Assay on Duration of Broad Spectrum Antibiotics for Gram-Negative Bacteremia. So just to start with the background, the majority of patients who are admitted with suspicion of infection are started on broad spectrum antibiotics, and that is not inappropriate. But we do see these antibiotics being continued for a long period, even when they are not needed. This is partly due to unavailability of rapid microbiological diagnosis and antibiotic sensitivity data. So we do not always blame the primary team. But what happens that as a result, we see emergence of resistant pathogens, particularly gram-negative bacteria. Also, long-term empiric therapy leads to increased incidence of C. difficile occurrence adverse effects like AKI, prolonged hospital stay, and increased mortality rates. Now, the conventional microbiology laboratory methods for positive blood cultures takes about 48 hours for organism identification and reporting the susceptibility results. And studies on rapid diagnostic testing have demonstrated improved clinical outcomes including decreased time to effective therapy and shorter hospital length of stay. Accelerate Pheno is a rapid diagnostic instrument that identifies gram-negative bacteria from signal positive blood cultures in less than 2 hours and reports antibiotic susceptibility results in approximately 7 hours. Now, these results are phenotypic MIC-based susceptibilities, meaning that when it shows that an organism is susceptible, if it's fully susceptible, if it's partially susceptible, or if it's fully resistant to an antibiotic. So Accelerate Pheno it uses fluorescence in situ hybridization technology for giving out the results, and it detects these 8 gram-negative bacteria, namely E. coli, Klebsiella species, Enterobacter species, Citrobacter species, Proteus species, Serratia mercescens, Pseudomonas aeruginosa, and Acinetobacter baumannii. I know there are limitations when it comes to the spectrum of organisms that it detects, but in our clinical practice, so the patients we see with gram-negative infections, these are the most common pathogens that we come across. So our hypothesis was that rapid identification and antibiotic susceptibility results of gram-negative bacteria in blood cultures will improve our stewardship practices and clinical outcomes. So this is a single center retrospective before-after observational cohort study. The pre-intervention time period was from June 1st, 2018 till November 30th, 2018, when standard laboratory practices were employed. And the post-intervention cohort time period was from June 1st, 2019 till November 30th, 2019, when we employed the rapid diagnostic testing results. And this was reinforced by review and reporting by the antimicrobial stewardship response team, meaning that the results would be reviewed by the team and conveyed to the primary team to make the antibiotic changes. And only first episode per patient for the study period was included. And the inclusion criteria was all admitted patients who were 18 years or older and received at least 72 hours of a systemic antibiotic and had a positive blood culture with the gram-negative bacteria. Exclusion criteria were all those patients who were transferred from an outside facility with an already established diagnosis of gram-negative bacteremia, had polymicrobial infections, or died or were discharged prior to the culture results. So a primary outcome was duration of broad spectrum antibiotic therapy. And our secondary outcomes included modification of therapy within 24-hour culture results, time to directed therapy, length of stay, subsequent multi-drug resistant organism infection within 30 days, C. difficile infection within 30 days, and 14-day in-hospital mortality. So coming to the results, we had 93 patients in the pre-intervention cohort and 131 patients in the post-intervention cohort. There was no difference in the patient demographics, including age and patient gender. Also, there was no difference in the encounter characteristics between the two groups, including PIT bacteremia score, Charlson comorbidity index, ICU admission while on antibiotics, and ICU length of stay. Also, we did not see any difference in the organism causing the infection between both the groups. So to talk about the clinical outcomes, we did see a difference as far as our primary outcome is concerned, and that is duration of broad spectrum antibiotics. The median duration of therapy was 4 days in the pre-intervention cohort, and it was 2 days in the post-intervention cohort with a p-value of less than 0.05. And we did see differences in some of the secondary outcomes, and I've highlighted those in yellow. First is modification at any point in therapy, which was 85% in the post-intervention cohort versus 69% in the pre-intervention cohort with a p-value of 0.01. We also saw a difference in the time to directed therapy, which was 18.9 hours in the post-intervention cohort versus 25.9 hours in the pre-intervention cohort. We also saw a lower incidence of subsequent MDROs in C. difficile infection in our post-intervention cohort with p-values of 0.01. We did not see any difference in the modification within 24 hours of culture results, no difference in the 14-day in-hospital mortality, and no difference in the length of stay. Now, highlighted length of stay in green because even though we did not see a statistically significant difference, but the median length of stay in the pre-intervention cohort was about 12 days. And in the post-intervention cohort, it was about 9 days. Now, that is a 3-day difference. And if you look at it from the cost effectiveness perspective, I think that is a positive finding and beneficial for both the patient and the hospital. I think we might be able to see a difference if we have a bigger sample size or if the study period is longer. This is just a bar graph redemonstrating the primary outcome of duration of prospective antibiotics, 4 versus 2 days. This is again redemonstration of some of the secondary outcomes. I wanted to highlight the fact that there's a big difference percentage-wise for the subsequent MDROs and C. difficile infection. For subsequent MDROs, it was 11 versus 2%, and for C. difficile infection, it was 9 versus 0.9%. So this is a bar graph showing the modified antibiotic, and in most of the cases, the antibiotics were de-escalated. But what I wanted to highlight that there were some cases when the antibiotics had to be escalated. In the case of meropenem and piperacillin tazobactam. So this is helpful because sometimes we have patients who have infection with a resistant bacteria, and if we have this information earlier in the hospital course, that can improve the clinical outcome. And even though we did not see any difference in the mortality, but again, I think with a bigger sample size, we might be able to see that difference. So just to wrap it up, Accelerate Pheno is one of the rapid diagnostic platforms. It has shown to improve clinical outcomes and lower the side effects related to broad-spectrum antibiotic therapy. And we propose that it should become standard of care in patients with bloodstream infections.
Wonderful. Thank you very much. That was outstanding. Potentially practice-changing intervention here. So let's open things up for a couple of questions.
I have a question. So we all appreciated when we evaluated the abstracts that this project really has the potential to change clinical practice. And if you can confirm in a larger cohort that indeed length of stay is reduced by 3 days, obviously that is a big deal. Can you tell us about the cost of the assay and the sensitivity and specificity in determining antibiotic resistance?
The cost analysis you said?
No, just the cost of the assay. How much does it cost when we order this test each time?
I'm sorry, but I'm not aware of that aspect. I think there's some reagent that we order, but the instrument is already in our microbiology lab. So I'm assuming it's more of a one-time investment upfront. And then I think it's just like any rapid diagnostic testing when you just have to keep on ordering the reagents.
This is Mel Weinstein. Tanea, do you want to respond to that? Otherwise, I can help answer that question.
No, you go ahead.
Just
making sure you're there.
So for those of you who don't know me, I'm one of the co-directors, one of the directors of the microbiology lab. This technology in particular costs about $200 a test. And you know that can be negotiated obviously with the manufacturer. It's not perfect, and what we've found is that it is particularly helpful for enteric gram-negative rods, what are now called the Enterobacteriales, like E. coli and Klebsiella, and the but it's not for every organism or every bug drug combination. So we've targeted its use where we see the greatest value. This type of technology is is going to transform how we take care of patients with bloodstream infections. And this is one of the first ones that's out there, and we were able to put it in our lab. But I think what you're going to see going forward is more and more of this, because there are lots of companies trying to develop similar types of rapid diagnostic assays.
Outstanding. Okay. Thank you, Dr. Weinstein, for your contribution. Dr. Arsalan, that was excellent. We will move on. Okay, thank you. Thanks, Dr. Weinstein and Dr. Arsalan. Our next presenter, Dr. Noah Mapur, is going to be presenting on choice of colonoscopy preparation and how it impacts the presence of intraluminal residual bubbles.
Thank you, Dr. Steinberg. I'm assuming my microphone's working well. So I will begin. So I'm coming to you now from cloudy Plainsboro, New Jersey, which is appropriate given that myself, Dr. Delator, Dr. Cabrera actually were fortunate enough to work with Dr. Risbud, Dr. Samoy, and Dr. Skoll on this project. So when you hear colonoscopy, I wonder what you think. If you are a medical professional, you may think to yourself, the gold standard for colorectal cancer screening. If you are a maybe a layperson, you might think, oh no, I have to go through this preparation and clean out. And if you are a endoscopist, you may say to yourself, I sure hope that patient cleared themselves out for this exam, because as we know, the rate of missed adenomas can range from anywhere from 2% to 27%. And a poor colonoscopy preparation actually risks increasing this adenoma miss rate to anywhere from 42 to almost 50%. Additionally, residual bubbles in the lumen of the colon are actually a often unspoken about issue in terms of visualization and adenoma detection rates. And this actually has not really been studied prior, and it's unknown to what degree it can actually reduce this detection of adenomas. And in general, there's limited data on what causes these residual bubbles.
Sorry, Noah, I didn't mean to interrupt. Your slide, the way it's presenting is just a little, I think it might be too big for the screen, so we're not seeing the whole thing. Maybe reduce the...
Let me see if I can fix that for you.
Yeah.
Thank you. Let's fix that. It did look a little funny on my end. How's that?
Good, perfect.
Very good. So as I was mentioning, a little aside on bubbles in general, simethicone is actually a solution we use to decrease, or gastroenterologists should say, use to decrease the surface tension of gas bubbles, and that can cause them to coalesce and disperse. And in studies, it actually shows increased polyp detection rate by up to 10%. Now this can be injected through the endoscope biopsy channel, as you see a little schematic of endoscope on the screen, or it can be added to the irrigation water bottle, and then that can be administered through the water jet channel. However, there are issues with simethicone that's becoming more and more prevalent in medical literature and in current practice. It's unclear how much degree this has in terms of infectious implications. However, there's been found to be a biofilm that can be left behind in the endoscopic channels on the endoscope itself. So this has actually resulted in several changes to reduce the risk of possible infectious implications. Most endoscopy units do not inject water using the water jet channel anymore, meaning simethicone is no longer placed into the irrigation water solution, or when it is used, the working channel actually is manually washed itself. Sometimes endoscopy units will actually process this endoscope twice, which can significantly delay and cases, and definitely has implications in terms of economics of our endoscopy units. And actually, two of the major manufacturers of endoscopes, Olympus and Pentax, have recommended against the use of simethicone in practice. So when we were looking at this study, we noticed no colonoscopy preparations or patient factors have been found to be associated with the presence of residual bubbles. And due to the inherent need for bowel preparation, multiple formulations available, and the direct effect they have on the colon, we wanted to explore the impact of bowel preparation on the presence of bubbles. So the purpose of the study is to identify factors that may increase the presence of bubbles, specifically colonoscopy preparation, formulations, or patient factors. So just going through our methods really briefly, is an IRB-approved, non-randomized, uncontrolled, prospective, single-center study. Patients received a screening colonoscopy from September 2019 to February 2020, were recruited. Anyone who had inflammatory bowel disease, bowel surgery, or undergoing a diagnostic evaluation, meaning not general screening, were excluded. And we employed a survey prior to their colonoscopy. So this included an evaluation of their diet for 48 hours. This quantified fiber, sugar, gelatin intake, water source they use for the preparation, dietary lipid or oil consumption, underlying health conditions, medication use, and chronic GI symptoms, and of course, the type of preparation used in the exam. After the exam was complete, the endoscopist documented if excessive bubbles, limited visualization, and if simethicone use was required. So looking at our primary objective, it was to identify the role of various preparations and their correlation with the presence of bubbles on that examination. Secondary objective, to identify various patient factors that are correlated with increased presence of bubbles, including patient demographics, comorbidities, medications, and dietary habits. So briefly, just to look at our a few slides from our survey, we quantified carbonation of carbonated beverage and consumption, gelatin product consumption, any foods which may or may not be associated with increased bubbles, types of sugar, sugar-free beverages, types of water consumed, oil used, dairy products, or any medical problems that they may, or comorbidities they had associated with them. And then going through some of the medications that you can see here, opiates, antidiarrheals, any inhaled medications, etc. So when we went through our statistical analysis, we compared patients with and without significant bubbles using chi-square, Fisher's exact, and Wilcoxon test statistics. A univariate analysis was performed to identify possible confounders to be included in our final model. We use a logistic regression with Miralax as the control preparation to identify the other preparations causing these large volume bubbles and possibly interfering with visualization. And we use the Strata version 16.0 for analysis. So table one, as you can see here, this is our demographic table. And just as a reminder, big takeaway points, this is not a randomized controlled trial. And patients across the stratified groups were similar, except for the comorbidities. And that we believe was just because there are higher amount of comorbidities in the PlenView, which is one of the preparations group. And that is skewed just to the lower number of patients in that actual, in that group who use the PlenView preparation. But in general, the mean age was 58 years, 47% were females, and bubbles are present about 27% of patients. Moving on to table two, we used a univariate model, like I mentioned prior, to identify additional factors that could be incorporated into our final model to really identify any risks for increased bubbles. And as you can see in this table, a big takeaway point is no correlation was able to be found between increased bubbles and age, female gender, comorbidities, medical comorbidities, dietary habits, or medications. However, getting to our table three, which we think was really the big takeaway from this project that we performed, was that the actual impact of bowel preparation agents on the presence of bubbles performed during that colonoscopy. So as you can see here with Miralax as our control group, we see that the ClenPick group were actually 58% less likely to have bubbles present during their colonoscopy with statistically significant p-value versus the Suprep, which were actually 86% more likely to have bubbles present during colonoscopy. No statistical significance could be found from the PlenView group. And again, just mentioning that, keep in mind the Miralax with the 180 patients were actually used as a control group. So of course, the obvious question is, so what's going into these preparations and how can that affect presence of bubbles. So just to break down very briefly these 4 preparations, you have the Miralax Prep, which is typically used, polyethylene glycol with a sports drink, Plenpick, as you can see the components there, Soup Prep, sodium sulfate, and a few other ingredients versus the Plenview, which is one of the newer ones that has more ingredients. And again, I think another question we might anticipate is, so why wouldn't I use Miralax versus Soup Prep versus Plenpick versus Plenview? And these newer, lower volume preparations, actually a lot of it has to do with insurance coverage and patient tolerability. So in conclusion, the findings of our study demonstrate that the type of colon preparation definitely impacts the incidence of residual bubbles, which then will go on to affect your adenoma detection rate, a very important factor for colon cancer screening. And we hypothesize further research is needed to assess what additional factors might affect the presence or absence of residual bubbles, and whether certain colonoscopy preparations should be considered exclusively for specific patient populations. And here are our exhilarating references, which I'm sure you'll go on to read on your own time after this presentation is over. So I thank you very much for your time, and I'm welcome any questions or comments.
Excellent, Noah. Thank you very much. We'll open things up to a couple of questions. While people are formulating, I guess the other issue is bubbles are obviously one factor that could influence the quality of the colonoscopy. Are you aware that any of these preparations are any better or worse in terms of what they're supposed to do in terms of cleaning out the colon in terms of effectiveness?
Great question, thank you. So as far as I understand, it's much more about the tolerability. They all should be equivalent in terms of the ability to fully clean out the patient for a easily visualized exam. And it comes down to lower volume and better tolerability. As we know, patients often complain about the disgusting, I quote, taste of that jug, another quote from patients often. So it really comes down to more of the tolerability and the volume that needs to be ingested.
There's a question in the chat. One of the variables assessed the speed of water injection. Was one of the variables assessed the speed of water injection used during colonoscopy?
We did not actually use that variable, but it's a great question. I think it does vary from what my limited understanding. I'm not a performing endoscopist just yet, hopefully in the future. But from what I understand, it may depend on the type of endoscope used, the diameter of the water irrigation jet and channel also may factor into that. But that was not one of the factors we looked into.
Excellent. Thank you very much. All right, wonderful. Our last oral presentation is Dr. Varun Basan. He's going to be presenting on disparities in drug-eluting stent utilization in patients with acute ST elevation myocardial infarction.
Thank you for the introduction. I'm just going to share my screen. Hi, everyone. I'm Varun. I'm one of the first-year cardiology fellows. So today I'll be presenting my study on disparities in drug-eluting stent utilization in patients with acute ST elevation myocardial infarction. I want to thank my mentors, Dr. Kasodis and Dr. Ankur Sethi. So let's get started with some background. So racial, socioeconomic, and gender-based disparities in cardiovascular care continue to be an ongoing issue, impacting the appropriate delivery of care. African Americans often have more risk factors for coronary artery disease, but then are less likely to undergo revascularization and receive evidence-based care for acute coronary syndrome compared to Caucasians. In patients with ST elevation myocardial infarction, or STEMI, drug-eluting stents have been shown to reduce rates of in-stent restenosis and repeat revascularization compared to bare metal stents. So the superiority of drug-eluting stents compared to bare metal stents has been well established in the literature. Newer generation drug-eluting stents have resulted in lower rates of stent thrombosis, in-stent restenosis, and myocardial infarction compared to bare metal stents. However, long-term data regarding drug-eluting stent use in STEMI among different racial and ethnic groups remains limited. Additionally, outcomes data in women with coronary artery disease of different ethnicities has been limited due to the poor inclusion of women and minorities in clinical trials. Prior studies in the literature have also demonstrated that low-income and uninsured patients are less likely to be referred for cardiac catheterizations, percutaneous coronary interventions, and coronary artery bypass surgery. So therefore, the impact of socioeconomic factors, including insurance status, on the decision to utilize drug-eluting stent versus bare metal stent needs further study. So we hypothesized that disparities in drug-eluting stent use continue to persist even today after many years of using drug-eluting stents and among minorities and lower socioeconomic groups, despite increasing national utilization. So the objective of our study was to compare drug-eluting stent versus bare metal stent utilization patterns in a contemporary STEMI patient population, and then look at disparities in the utilization based on race, socioeconomic status, and gender. So for our methods, we also utilize the National Inpatient Sample Database using a retrospective analysis to compare drug-eluting stent versus bare metal stent utilization in patients admitted with STEMI. We had a quite robust population size of over than 935,000 patients. So drug-eluting stent and bare metal stent utilization trends were assessed from 2009 to 2017 in different groups, including whites, blacks, Hispanics, Asian or Pacific Islanders, Native Americans, and other, as defined by the NIS database. And we utilized a multivariable logistic regression analysis to assess the independent predictors of drug-eluting stent use. So here I'd like to bring your attention to this pie chart, and this just illustrates the different groups that made up our data sample. So as you can see, we had a variety of different groups, which I just went through, but Caucasians were a huge chunk of that, more than 75%. About 540,000 were Caucasian, only 48,000 to 49,000 patients were African-American, about 52,000 were Hispanic, and a little over 18,000 were Asian or Pacific Islander. Native Americans were only about 3,700. And in the other group, we had about a little over 26,000. So now I'd like to take a moment to really emphasize some details about the NIS database, because I think it's a very robust and unique database. It's the largest publicly available all-payer inpatient care database in the United States, and it's based on billing data. So it provides us estimates of inpatient utilization, access, charges, quality, and outcomes. As an all-payer database, it includes patients covered by Medicare, Medicaid, private insurance, and those that are uninsured. And it's important to note that it covers greater than 97% of the United States. And each year of data from this database includes over 7 million hospital inpatient stays. So it is also sponsored by the government and the Agency for Healthcare Research and Quality. So it's a robust database. For our statistical analysis, we define categorical variables as proportions or percentages, and continuous variables were presented as means with 95% confidence intervals. We used chi-square analysis for categorical variables and a t-test to compare continuous variables. And again, we use multivariable logistic regression to adjust for confounding factors to assess the independent predictors of drug-eluting stent use. Now I'd like to draw your attention to this figure where you see a histogram of the different groups. So now going from left to right on the x-axis, you see the years from 2009 all the way to 2017. So, and then on the y-axis, you see the percent of drug-eluting stent utilization from 0 going up. And of course, you have our key groups: Caucasians, African-Americans, Hispanics, Asians or Pacific Islander, Native American, and other. So as you can see, going from left to right, there was a significant increase in utilization from 2009 to 2017 in each group. And overall, drug-eluting stent utilization increased from 62.8% in 2009 to 90.6% in 2017. So very interesting trend. For our results, I want to emphasize that African Americans were still less likely to receive a drug-eluting stent compared to Caucasians, with an odds ratio of 0.8 and a significant p-value and confidence interval. This is after adjusting for other confounding variables. Additionally, patients insured by Medicaid and classified as self-pay were also less likely to undergo drug-eluting stent implantation compared to those with private insurance. And we have significant odds ratios here. Interestingly, females were more likely to undergo drug-eluting stent implantation with an odds ratio of 1.07 and significant p-value less than 0.01. Now, I'd like to draw your attention over to this chart here, where our parameters are all on the left, and I've demonstrated the odds ratio, p-values, and upper and lower limits for the confidence intervals. So patients, interestingly enough, insured by Medicaid who are female were less likely to undergo drug-eluting stent implantation. And same thing with self-pay. And that follows the overall trend in our data. However, African-American females were less likely to undergo drug-eluting stent implantation. And remember that females overall in our data set were more likely to undergo drug-eluting stent implantation. So this is definitely something different, where African-American females were at a disadvantage and less likely to undergo drug-eluting stent implantation. And again, you can see that Hispanic and Asian or Pacific Islander, in those groups, those females were more likely. And Native Americans, there was no statistically significant difference for them. Next, I'd like to chat about mortality. So this is another chart that outlines mortality in our patient population with STEMI. Those who received a drug-eluting stent had a lower likelihood of mortality, and that's shown here, as you can see, with an odds ratio of 0.58. Now, those who were insured by Medicaid or classified as self-pay had an increased likelihood of mortality compared to those with private insurance. African Americans, interestingly enough, had a lower likelihood of mortality. While they were less likely to undergo drug-eluting stent implantation, they did have a lower mortality. And Hispanics and Asians or Pacific Islanders had an increased likelihood of mortality that was statistically significant. Just going to take a moment to briefly highlight some limitations. So the NIS database, being something that's based on billing data, is limited by data entry and coding and billing diagnoses. We adjusted for confounding variables, but it's possible that there are some that impacted our data set that were not accounted for by the multivariable logistic regression analysis. And our study period from 2009 to 2017 really does span quite a bit of time, but more recent years may not be captured. But I think our data is still quite compelling given it's from 2009 to 2017. So in conclusion, disparities based on race and insurance status continue to persist despite a significant increase in drug-eluting stent utilization in STEMI patients across all groups during the study period. Again, African Americans were still less likely to receive a drug-eluting stent compared to Caucasians. And while females were overall more likely to get a drug-eluting stent, African American females were still at a disadvantage and less likely to receive a drug-eluting stent. So further study is definitely needed to understand the racial and socioeconomic disparities in drug-eluting stent utilization. Future studies really need to look at physician decision-making to help address gaps in care and achieve better outcomes. We really need to understand those physician or provider-related factors contributing to the decision-making by cardiologists and understand the barriers to drug-eluting stent implantation. And again, I want to emphasize that STEMI is such a prevalent diagnosis and admission diagnosis that this is a very important problem nationwide. And these are my references. Thanks so much for your attention. And I want to, again, say a special thank you to Dr. Casotis and my mentor, Dr. Sethi. And just a side note, this presentation was presented recently at the American Cardiology College of Cardiology Scientific Sessions, and the manuscript is currently underway.
Outstanding, really very impactful results that have really important implications in our society. So thank you, and that was a wonderful presentation. We'll open it up to a few questions. And so as a non-cardiologist, and I know this has been going around for a long time, what would the clinical indications be at this stage of the game for not using drug-eluting stents?
So some of the reasons why interventionalists will pursue bare metal stents is if they think that there's a significant risk of non-compliance, and the literature has shown that sometimes in lower income groups, patients who are less likely to be compliant or more likely to have bleeding complications, that sometimes they will pursue bare metal stents in those patients.
So clearly, we can obviously see that there's a major opportunity for stigma to come into the decision-making process here. And that's why this is such an important issue to bring up.
Definitely, and it's up to us to bridge the gap. I think, looking back, drug-eluting stents have been around since the early 2000s, and it's been so many years since they came into practice. And the fact that disparities still exist, I think is an important point. So it's up to the future generations to really bridge that gap.
Other questions? Hearing none. Again, I want to thank all of the presenters. I'm very impressed, not only with the subject matter and your abstracts, because we reviewed those as a committee, but you all did an outstanding job with presentations, well polished, clear, concise, right on time. So very impressive, very impressive. Thank you all. Okay, so for the remaining time in our session this morning, what we're going to do is I'm going to announce the winners of the poster awards that were selected. I'm going to list the awardees and their titles. I think what we can do is, if we can put back up the posters, the sequence of posters, so people can spend some time, a few minutes, seeing all of the posters that were submitted. I just want to once again thank the Sodhani Family Foundation for their generosity and the awards that we're able to give to the trainees. So thank you, Mr. Sodhani. I want to thank the judges who spent time in their busy schedules to review each and every one of these abstracts. They did a great job. I want to thank Dr. Butner, my co-vice chair for research, Dr. Sharma, always for her support of our trainees, and especially Rachel Stewart, who basically pulled this all together once again. So thank you very much, Rachel, for all your help. So I'm going to announce our awardees in no particular order. So these are the posters that were selected by our committee. Dr. Andrew Newman on glycemic management in CABG surgery patients by telemedicine versus in-person consultation. Dr. Scott Bentry, curative surgery after EUS-guided biliary drainage, an international multi-center feasibility study. Dr. Andrew Aboime, diagnostic factors in COVID-19 patients with atrial fibrillation and atrial flutter. Dr. Savan Kabaria, frailty is associated with high readmission rates and mortality among diverticulitis patients, a nationwide cohort study. Dr. Alexis Ako, association of prosthesis oversizing or undersizing balloon expandable transcatheter aortic valve replacement and clinical outcomes. Dr. Amy Sohotliv, do elective cardiac procedures increase risk of symptomatic COVID-19 transmission with current hospital precautionary measures? Dr. Chukwuka Akamnonu, evaluation of thrombotic risk in thyroid cancer. And Dr. Pranav Sharma, a retrospective analysis of fluid balance in patients with acute kidney injury and respiratory failure due to COVID-19. So those 8 submissions were awarded recognition. I want to congratulate all of the recipients, all the winners. I want to thank all of the trainees for their submissions. Again, they were all outstanding. This was a very difficult decisions, but everybody did a great job. I want to thank all the mentors for their hard work on making these presentations possible. And once again, thank all of you. I don't know if there's anything else we need to discuss, any of my colleagues. And if not, maybe we can give people a chance to once again review the posters if we're able to put them back up for people to view.
Dr. Steinberg, I was so happy to see Dr. Weinstein on after a long time.
He's never leaving us. Never leaving us, one way or the other.
He's the one who instigated me, inspired me to do something, So I really want to thank him also, and Dr. Steinberg, you too, and Dr. Anita Sharma for excellent job of presentation and encouraging all the youngsters and fellows and residents. And wish you all the best for the future, and we'll continue to support whatever we can to the best of our ability. Thank you very much.
Thank you.
Thank you, Mr. Sodhani.
Oh, here we go. Thank you, Rachel.